I just think it's so exciting that we've got both the FLAIR trial and the STATIC trial are both being described as unique developments. And I just wondered if Dr. Munir and Professor Alsop could just say a little more about how exciting that uniqueness is, because in the UK we may take it for granted, and I just would like you to put it into perspective a bit more.
Maybe I can just start and then Dave can comment as well. I think, you know, myself and Dr. Alsop have been working with Professor Hillman for some time, and I think it's unique in quite a lot of ways. That one, FLAIR is the largest trial that has recruited over 1,500 patients, CLL patients, and I think that is a feat on its own, because normally one has to recruit from multiple countries actually to be able to get a trial of that size. So that's pretty impressive on its own, really. But the second unique thing of FLAIR trial, in my opinion, is the adaptive design. So normally a trial will have a very fixed question, and you answer that question and you move on. But life is not like that. We found out in the life of a trial that actually we have to make changes. And I think in terms of the adaptive design, this is the only trial that has adapted to the needs of the CLL community. So I think those are the two unique things, really. And the questions that we are trying to answer are very, very, very relevant still now at this moment in time. So that has taken the leap, you know, a leap forward really from that perspective. And in terms of STATIC trial, all I would say is that nobody else in the world is looking at this question apart from the UK group. So, and it is a very relevant question, in my opinion, because we certainly are not going to get this answer from any other group in the world. So maybe David can add something to that.
Yeah, I'd obviously agree with that, and I'd say that the adaptive element of FLAIR is effectively a personalised approach. So it's accepting that different CLL or different people with everyone's CLL is different, and it's really trying to design an approach that is individualised and personalised. And people like us have been talking about personalised medicine for well over a decade now, and it's still not quite arrived. And this is really sort of trying to push that forward to try and make it more targeted and round the individual. The other things about FLAIR and STATIC is anyone that's taken part in the trial will know they've signed forms to say, can your blood go off and be stored in Liverpool? And it's signed forms to agree or not agree for other research to be done. And behind the scenes, there's a whole almost army of scientists all around the country in places like London and Brighton and Cambridge and Liverpool, who are doing research on the samples that are kindly donated by people to really learn more about what's actually driving the leukemia, and to try and answer some of the questions around what treatment works best in under which circumstances. So there's a whole load of other work that's going on with dozens of very, very capable, internationally recognised experts behind the scenes.
And Lelia, I know you've got lots of previous experience in clinical trials, and we're so lucky to have had you on FLAIR and STATIC. And I've been so lucky as a newbie on the STATIC trial to have you as my mentor, if you like. I just wondered, it seems as though having the website is really big progress. Would you agree that that's one of the things that is really exciting about the trial?
Yeah, no, I think it's it's really good that it's something we've talked about a lot. So it's certainly very exciting to see it realised at last. And it's not as easy as it sounds. You know, there's a lot of so-called patient-facing websites or information that are actually not so easy to understand. So we've had a lot of discussion about how to do it and what information to put up there. So certainly if there are people listening to this who have seen it before or are seeing it for the first time and have suggestions about how we could improve it, that would be really helpful. And yes, it is exciting to have it's a next step really in having a much more interactive relationship, more appropriate for the 21st century. You know, it's, you know, everyone's, you know, getting more input from people taking part in the study and from the CLL community more widely can only help in terms of understanding how we can do the study better.
And previously we were getting updates on the CLL support website, weren't we? But now we've got real-time updates happening on the website, so that's brilliant.
Yeah, and that should continue. And as Rhiannon said, once we've got results, I think it's absolutely important that people who took part in the study and people who have the condition should hear the results at the same time as the academic communities who hear them, as you've heard from Tal and David at the conferences. So we should be presenting that, we should be making those results available in real time at the same time as they are to the doctors and the clinicians around the world. So yes, it is a really, and I think it's got way to go. It's something that we've started that will continue to evolve, Hilary, which is also really exciting.
And I think we want to give Rhiannon a right of reply, as she's the one that made it all happen.
No, we're really excited to have it up and running, and I think, as Lelia says, it's really important. It's the next big step. Everything in the world is changing, and we need to make sure that we're keeping up with that. So yeah, we're very happy to have that available now.
Good. We've got quite a few questions in the Q&A area that I'll raise with you if I may, and do keep putting them in there if you still haven't. But I've got a question here about, does acalabrutinib now make ibrutinib redundant? So that's a question for Tal or David, I would imagine.
I don't think it makes it redundant at all. I think it's still a very good drug, but we are all aware of the issues that we see with each and every one of the molecule that comes along. There is going to be side effects that are related to it, and the trials actually have shown that ibrutinib is as effective as acalabrutinib in relapsed refractory CLL. So I think it's still a very effective treatment. Our job as clinicians as well as researchers is to make sure that we look at the evidence in the best possible way, and also make sure that we make the combinations, the treatments as safe and effective as possible. So I know where the question is coming from, but I still think ibrutinib is still a very effective treatment. We just need to make sure that we take all the safety precautions that we can take to make these drugs as safe as possible.
I'd also say that the vast majority of persons with CLL that I've treated with ibrutinib have done very well with it, and both myself and the people treated have been very pleased with it. And decisions around treatment are obviously individualized, and for some people therapy based around ibrutinib might be the right thing to do, but there are newer treatments that are such as acalabrutinib and zanubrutinib that are highly effective and possibly have a different and better safety profile. But someone like myself that remembers therapies going back 25 years, you know, thinking about where we come from, ibrutinib's a fantastic treatment compared to where we were sort of 10, 15 years ago.
And another question around acalabrutinib. Will patients on acalabrutinib as first treatment be considered for the STATIC trial?
Unfortunately, no, at the moment. That's only for the patients who are getting acalabrutinib in the second line therapy. So we have not, the frontline patients are the patients mainly coming from FLAIR study, but there would be other patients who've received ibrutinib in NHS or in the private setting who would be able to go into the study. So the answer is unfortunately no at the moment.
And then the question about people who are on FLAIR for 6 years but are not on STATIC. how are you monitoring the remission or the disease progression for them?
So one of the aims of static trial or FLAIR trial was to keep it as simple as possible, and the monitoring should be done as we would normally see our patients in our clinic. So patients who finish 6 years of FLAIR therapy will still be reviewed by the trials team to get some data so that we know what is the outcome after that. So if, say, for example, the patients did not want to go into static study or the trial was not open, we would love to get patients on, those patients onto static study. But if they can't, if they haven't gone onto it, then the physicians, the hematologists looking after them will be monitoring for any progression, doing the blood test, making sure that the disease is not progressing as they would normally do, which is in our routine would be every 3 months monitoring, which is normally done by most of the hematologists. So I would hope so that that would happen on for those patients. But then we do collect data every year for those patients for the trial as well, so that we know what is happening with those patients as well.
Thank you. And another question about what trials or other treatment might be available for somebody that's onto their 4th line of treatment?
There are many treatment options. I've seen that question. It's very specific there are lots of options in that space as well. It would be difficult for myself or David to go into detail for that in that setting, but I would certainly advise that speak to your hematologist, and there are clinical trial options. There are options available on NHS that would be available. So have a chat with your hematologist, and there are options there. That's all I can say. But if you have any specific questions, you can always contact us directly to answer any questions.
You can contact us through the website, presumably now, Rhiannon, can we?
There's details of who you might need to contact are all on the website. And generally speaking, if it's to do with kind of eligibility and things like that, then you would need to speak to your clinicians. But yeah.
And a question about the Bristol Hospital. So somebody that's ending FLAIR in next February, and Karen would need to move, and will that stop them continuing their ibrutinib?
So if your hospital that you're currently receiving FLAIR treatment on isn't open to static, it's not a problem. You can be transferred to another hospital. That's not a problem, and that wouldn't impact your ability to be on static.
Good. And then somebody here suggesting that we let everybody know there are more than 100 people on this call, and therefore there's a lot of interest in this, and that we're all part of a community rather than having a disease or an illness that makes us feel separate, if you like, a bit isolated at times. So I think it's good that we should celebrate that. And then a question about the static website.
I think the question is saying that the new protocol does include the acalabrutinib for 3 years and lymphocytes less than 4. Yes, certainly that would allow more patients to go into the study. Yes, so hopefully that should be open from January.
Yeah,
I'm just not able to update the website until it's finally approved, are we? Is that
exactly?
Yes. When we were working out the timing of this webinar, we were trying to work out when was the best time to share the amendment to the trial. So
yeah, we can't put it out unless it's we've got all the signed forms and everything through their text. So that's why it's not there on the website at the moment.
Yeah, Tal, is it worth just adding there that folk, I think, don't often people don't realise how long it takes to get what's considered, appropriate approvals. I mean, Rhiannon can probably say something about that, but it's something it's quite a lengthy process, isn't it, Rhiannon? It sounds, why can't we just do it? But actually, it takes a while.
Unfortunately, there's a lot of things that we have to do for very good reason. But there are a lot of kind of regulatory bodies that have to review it. Obviously, we have to get a lot of input from kind of everybody really. So clinicians involved, statisticians, our PPI members, people who are funding the trial. But also then once you've kind of decided and agreed all those changes, you then have to go to kind of the overarching governing bodies within the UK, and they check it to make sure that they're happy that it's ethically sound, that it's safe. And it's not until we have all of that we can then roll things out, which sadly, does take a bit of time.
And Lelia, you were saying if anybody had got any ideas about the website, somebody's asking if the website could include a patient forum or experience section. I expect you can't answer that immediately.
It's on the wish that we have discussed it in the past. And in fact, that's why, in a way, why I was emphasizing it's the first step with the website, because if we try to activate everything that we would like to have, our full wish list, it would have taken us another 2 years. And in the end, didn't we, Rhiannon? We went for something that we could just get started. Yeah. And then this kind of discussion is really helpful in prioritizing what we do next and what we activate next.
And somebody was asking early on, are there any results yet from STATIC or any indications? But I suspect it's too soon too.
We did have some data coming through from I mentioned that in the presentation, that some just due to the COVID pandemic and our inability to open FLAIR, a STATIC trial in time, we had some patients who came off the study, and we've looked at is the intermittent approach going to be worth looking at, and there is a publication that we're going to be doing in due course. So initial experiences that probably it is the right approach to take, but we can't answer that question unless we have recruited in the trial and looked at it properly.
And then somebody's asking, how is pirtobrutinib looking?
Pirtobrutinib is another BTK inhibitor, and David already spoke about the covalent BTK inhibitor. It's what we call as non-covalent BTK inhibitor. So just looking at the third or fourth line therapy, that's where this drug is sitting at this moment in time, but it is also being looked at in a number of clinical trials, whether this is going to be a drug which is going to be better than the drugs that we've already got. But this is all in clinical trials at the moment. The place where a lot of us are happy to use it is probably in the question that was asked earlier.
And another technical question about, has the way the drugs are ramped down changed?
I think the question probably relates to venetoclax. So I've been asked this a few times in clinic. So with the tablet treatment venetoclax, we have to be very careful. The problem with venetoclax is it works so well that it causes all the leukemia cells to die off very quickly, and that can produce a transient problem with affecting how the kidneys work. So because of that, we introduce it slowly over a period of 5 weeks or so and build the dose up. But the opposite is not the case. When you discontinue it, you don't need to then subsequently ramp down if you discontinue it. And with tablets like ibrutinib and acalabrutinib and zanubrutinib, if you're choosing to stop them, then you just stop them.
Another question about the support tablets. Are they the same for all these treatments and treatment combinations?
There isn't actually. There's quite a lot known about the effect that CLL has on the immune system and in terms of increasing infections. There is a debate actually about how much tablets like ibrutinib or acalabrutinib, whether they suppress the immune system or not. And there's a school of thought that says because these treatments work so well and the leukemia is pushed right back, it allows the body's natural immune responses to sort of start working again. So standard practice is to give something like cotrimoxazole to prevent a certain type of chest infection, and then practice varies a bit around whether you give other anti-infection medicines. So the clinical trials that are done when someone like Tal or myself does a clinical trial for a drug company of something like pirtobrutinib, usually buried deep in the instructions about the trial, it says you give these anti-infection medicines according to what you normally do. It doesn't normally prescribe it. So, but it's a similar approach with all of them, yeah. So whatever the risk is, and it's probably not that great, it is similar. So people tend to do the same thing with all the drugs. But practice does vary a lot around the country.
Right. And then a question about Worthing Hospital. I don't know if you can help with this, Rhiannon. Somebody's completed the 6-year FLAIR trial at Worthing, and if they enter static, will they need to change their haematologist?
So it would depend on where they went to instead, and kind of the local policy, and if they're within the same trust and things like that. But there's potential that it may be the case, but it would depend on the hospital.
And you mentioned possible satellite hubs, did you?
Yes, so something we're looking at. We don't know yet how, if or when this will be possible, but we are looking at kind of using, satellite hospitals. So you would have one main primary hospital where you're kind of recruited and you have to have occasional visits, but then you could hopefully the plan is that you could then continue to have more regular appointments at perhaps your other hospital where perhaps you've had your FLAIR treatment, or your GP clinic, things like that. So we're trying to look into that at the minute as another option for the trial, which we hope would make things an awful lot easier for hospitals and patients. But it's something that we're kind of considering and working out the logistics at the minute. So hopefully we can update that on that next time.
Yeah, I just have to add in that it's a like the amendment we talk about. It takes time to get all the approvals in place, and similar to that, this kind of work plan, trying to open satellite sites, it's a lot of work, and we have to have contracts in place and other things with individual trusts. So we are looking into that and trying to make it as easy as possible for people to get into the study. But if you're in the FLAIR study and your site is not opening for static, please do get in touch with us. We can get you, we can make you aware which is your local site, which may be able to recruit you, and we can always direct the PIs to talk to each other to say whether they would accept the patients coming from a region close by. So yeah, we're trying to make those changes, and we do understand that that's a problem, but these changes will take some time to implement.
And we very much believe at CLL Support that what we all want to try and become is an informed patient. So I think what we're very much trying to do with this webinar and with all the information on the website is to encourage people to go out there and find out what's happening and what the possibilities might be, and then ask questions of where you're getting your treatment to see what might be possible for you. I think that's our own responsibility to ourselves, if you like. I think we ought, before we end, I ought to give Dr. Munir and Professor Alsop and Lee and Rhiannon a chance to ask each other any questions they want to.
Tal, do you think static will be opened up further beyond acalabrutinib to other tablet treatments like zanubrutinib, for instance?
It's a very good question, Dave, and I think we probably would just have the acalabrutinib treated patients. It's unlikely that we will allow the zanubrutinib treated patient, just because how the trial is, what's the length of the trial, and when does our funding finishes. All of those questions need to be covered. We're hoping that once we've got the acalabrutinib arm of the trial open, we've got a much larger number of patients who can participate in the study, hopefully. But we will keep an eye on things, and if we are, from our history that we adapt as we go along as well. So we'll see how the things go.
Yeah, I was just going to nudge Tal slightly, because something you say quite often in the meetings, Tal, is that doing it within static is the best way to pause treatment and to find out whether it's a good thing to do or not. And I wondered if you wanted to just elaborate on that a little bit.
Yeah, that's a fantastic question, and I think I'll repeat myself here. But in terms of the clinical trial, what we are looking at, and David already alluded to that, is not only looking at the clinical question, which is very important, but also looking at the samples that our fantastic patients have been able to contribute to the biobank. And we are able to look at all of those mutation questions and a lot of research samples that are going to go into. Not only we are very effectively monitoring our CLL patients clinically, but also looking at the quality of life of our patient. Is this approach the right approach to take? And lastly, increasing the research side of things as well. We're answering very important questions. So I think, in my view, if you are going to stop a therapy, this is the best way to do it, because all eyes would be on you, just to make sure that we don't miss a thing there. And I think that is an important message that needs to come across, hopefully can come across.
So thank you all so much for speaking on the webinar, and also to everybody for your questions on the webinar. I wish you all well. Thank you.